CE, if you're claiming CE credit, it's due December 27th to Megan Patel. If you guys are here, the papers are in the back of the room, so feel free to fill those out. So today we're going to talk about CRT, and the reason I chose this topic is because acute renal failure happens in about 5 to 25% of the critical care population, and about 6% of those patients that develop acute kidney injury will go on to require continuous renal replacement therapy. So it's commonly seen in our ICUs, and we do see a lot of patients, and so I really want to increase staff awareness to help improve drug dosing and the care of these patients. So after today's lecture, I want you guys to be able to identify indications for CRT and discuss the different modes of CRT. And then more importantly, I want you to be able to explain the different anticoagulation methods that we use to be able to monitor for and identify citrate toxicity, and then to recognize factors that are going to affect drug dosing in patients on CRT. So just real quickly, I want to talk about some of the causes of acute kidney injury. So AKI is very commonly seen in the hospital, not just in the ICU population. And a lot of things can cause AKI. Most commonly in the hospital setting, we're going to see hypovolemia, ischemic injury, contrast-induced nephropathy, sometimes some post-obstructive nephropathy, not quite as commonly seen, but still seen in our patients. So the definition of AKI per the KDIGO guidelines is any of the following that's listed here. So an increase in serum creatinine of greater than 3 from the patient's baseline within 48 hours, an increase in creatinine to above 1.5 times the patient's baseline within the prior 7 days, or patients with urine output of less than 0.5 mils per kilo per hour for 6 hours. And so I just want to kind of define that so you guys know what patients we're talking about, and to be able to identify what patients actually do meet criteria for a diagnosis of AKI, so you can be monitoring for interventions that we do for those patients. So I'm going to briefly discuss the indications for CRT and dialysis, and I'm sure many of you guys learned in school the AEIOUs, so we'll briefly go over those. A is for acidosis, E is for electrolytes, I is for intoxication, and here we're talking about any kind of ingestion or drug overdose that's dialyzable, overload, and then uremia. And overload, we're referring to like a volume overload. So I've got acidosis, electrolytes, and intoxication kind of starred here, and that's because these really, these indications, CRT is not ideal to use for these indications, primarily because the rate of clearance is so slow. Much slower than intermittent hemodialysis. So if your patient is acidotic or has electrolyte abnormalities or has an acute intoxication and we need to rapidly correct that, CRT is not going to rapidly correct that. So if a patient can tolerate intermittent hemodialysis, that would be the preferred mode of renal replacement therapy in those patients. You can see some other indications over on the right-hand side of the screen. Sepsis, there's kind of conflicting literature on this right now. Patients with increased ICP or brain edema, CRT is actually the preferred method of renal replacement therapy in these patients, and that's really because it avoids rapid drops in blood pressure that can decrease your cerebral perfusion pressure. And also it has a slower rate of solute shift and will not cause the dialysis disequilibrium due to rapid intracellular shifts. And so it really is the preferred method in those patients. And then also it's preferred in patients with hemodynamic instability. And so if you can think how rapidly the blood is being removed and fluid is being pulled off of a patient in a 3.5-hour intermittent hemodialysis session, we're able to extend that removal and do it over 24 hours versus 3 hours. And so patients that are hemodynamically unstable will tolerate CRT a lot better than they will intermittent hemodialysis. So just want to talk about some of the advantages and disadvantages of CRRT. Advantages, again, hemodynamic stability. It's a lot easier and to tolerate as far as blood pressure goes. It does have a continuous solute, provides continuous solute control, so it's a lot easier to control sodium, for example, in a patient who has elevated ICPs. We've got easy volume control. You can change the rate of fluid removal at any time, and you get fewer fluctuations in ICP. And then there's possibly some literature hinting towards maybe some increased renal recovery when patients are started on CRRT. And that's, I think, still up for debate, but there is some newer literature looking at that. So we also want to recognize some of the disadvantages of CRRT. And like I said earlier, it's got a slower rate of toxin clearance. So again, patients that are acidotic, have an acute intoxication, are hyperkalemic, are not ideal candidates for CRRT. You do need prolonged anticoagulation. It's much, much more costly and typically requires a one-to-one nursing ratio. Patients are typically hypothermic, and that's due to the blood constantly being removed from the body and cycled through that big machine. And so it's very, very difficult to recognize infection in these patients. Patients typically will not spike fevers on CRRT, and if they do spike a fever on CRRT, you can expect that their real temperature is probably much higher. Patients are immobilized because they have these big vas calves in place, and so moving them to the scanner, trying to take them to surgery, they're not getting up for PT, those are all issues. Drug clearance, so we think about that and think, well, we want to be able to have a therapy that can remove some intoxication, but you have to remember that a lot of these patients are put on CRT because they're septic, right? And so if we're giving them antibiotics, now we're pulling off all the antibiotics and probably not reaching the PK and PD parameters that we need to treat the infections in these patients. And then nutritional losses, it's tons and tons of protein loss, and so these patients are requiring massive amounts of protein, either enterally or parenterally. They lose a lot of vitamins and minerals through the circuit, and so these are all things that have to be considered and adjusted for when patients are on CRRT. So I want to discuss the modes of CRRT, and I'm going to point out the ones that we use here at Erlanger. And I do think this is important for you to understand, especially if you go to other places and see other ways that CRRT is run, and there's multiple different ways that CRRT can be run. So I want you guys to kind of recognize these. So the first one we're going to talk about is slow continuous ultrafiltration, or referred to as SCUF. And this essentially is only used for volume control. You are only removing volume in these patients. There's no dialysis that occurs, no solute removal. And so there literally, the blood comes in through the filter, and the effluent, you kind of think of this as your pee bag, is the fluid that you're pulling off of the patient. There's no replacement solution used here, okay? So you would not see Prismasate ordered in these patients. Now this is important because when you walk by a patient's room and you're just kind of glancing at them, maybe on rounds, and see this big green machine there and say, oh, they're on CRRT. Well, they may not be getting CRRT like we're thinking CRRT. So you can't automatically assume that you need to dose adjust all of their drugs up, because drugs are not going to be removed in this form of dialysis, okay? So it's important that you really pay attention to what's going on and not just see that big green machine and say, oh, they're getting dialyzed, okay? We don't use this mode frequently at all, probably maybe 3 to 4 times a year, but we do use it here. So it is something to be aware of. Okay, next mode is CVVH, okay, so continuous veno-venous hemofiltration, and this removes solutes via convection, okay? So we have a replacement solution here that's provided either pre-filter or post-filter, and it's actually it's creating a hydrostatic pressure gradient that's pulling solute across that filter membrane, okay? And so it does require a replacement solution. We don't do this mode here, okay? But I just want you to be aware of that. Next mode is continuous veno-venous hemodialysis, okay? And so this is a diffusive method. So this is the same method that's used for intermittent hemodialysis. So talking about random motion of molecules across a semi-permeable membrane, okay? And this requires a dialysate solution. So when we combine those two, continuous veno-venous hemodiafiltration, we have both a convective and a diffusive method of solute clearance. Okay, so this will require the replacement solution for the convective clearance and a dialysate for the diffusive clearance. This is the type of CRT that we run here at Erlanger 99% of the time. So you've got your blood flow coming in through the filter, and you're going to have your replacement solution here in the purple. We always do this post-filter replacement solution because the machines that we have require post-filter replacement due to a blood-air interface to reduce filter clotting. Okay, so that's not probably super important for you guys to know, but our replacement solution is provided post-filter. And then we've got a dialysate here that's going to run concurrent to this blood flow, okay? So now we're going to talk about anticoagulation, and the KDIGO guidelines recommend assessing the risk and benefit of your patient for use of anticoagulation, but do recommend that if you are going to run CRT, that in patients that do not have a risk of bleeding or you think that the risk of anticoagulation would outweigh the benefit, they do recommend anticoagulating the CRT circuit, no matter what device you're using. And so we will talk about the different modes of anticoagulation that are available here. You obviously can run no anticoagulation if your patient is not able to tolerate anticoagulation. Unfractionated heparin is an option, and citrate anticoagulation, which is a regional anticoagulation within the circuit, is also most commonly used. We do not use low molecular weight heparins for anticoagulating our circuit here, but it is done elsewhere. And then thrombin antagonists can be used if your patient has HIT and needs something like argatroban that can be used. But the three kind of methods that we go with here at Erlanger are either no anticoagulation, heparin, or citrate. So first I'm going to talk about citrate because this is probably one of the most common modes of anticoagulation that we're going to use. And this is referred to as a regional anticoagulation. So we're not actually systemically anticoagulating the patient. We're just providing anticoagulation within that CRT circuit. So citrate binds to, this is a picture of the clotting cascade, obviously. But citrate binds to calcium, and so you can see all of the different areas in the clotting cascade where calcium is required for the body to form a clot. And so essentially by giving people citrate, we're chelating that calcium, and the body is not able to, or the blood is not able to clot. So this is just a schematic of how this kind of all works. So we've got our patient here, and the blood is coming out of our patient. And before that blood hits our CRT filter, we're going to be giving the patient citrate. Okay, so all through this line, the citrate is going to be chelating the calcium in the blood. Your blood is going to come in through the filter pretty much without calcium, and then it's going to come out the filter and return to the patient. So obviously, when we bind up all of this calcium and then return that blood to the patient, that's probably not a good thing for the patient. So we need to restore the calcium once it's returning to the patient, because after we've left the filter, we no longer care if that blood can clot, or we want that blood to be able to clot. So then we provide a calcium infusion to the patient systemically to kind of replace that calcium. And so when we're talking about the dialysate and replacement solutions that we're using, recognize that these are coming in contact essentially with the blood that's going through this filter. And so it does not make sense to provide a replacement solution or a dialysate that contains calcium, okay? Because you're essentially undoing what your citrate is trying to do. I will explain one caveat to that in a little bit, but in general, you would not use a calcium-containing replacement solution or dialysate when you're using citrate. The other thing I want to point out here is we're going to talk about patient ionized calciums and blue port ionized calciums, or the circuit ionized calcium. So there's a port at the end of when the blood comes right out of the filter, and this is going to tell us the calcium level of that blood coming out, okay? So essentially, it's going to tell us how anticoagulated the blood is within this circuit, okay? So that's important because we have to titrate our citrate and our calcium to make sure that we're attaining the appropriate level of anticoagulation. So the circuit ionized calcium is the blue port. It's drawn from the blue port on the machines that we have. And our goal here is for an ionized calcium of 0.3 to 0.4 millimoles per liter. So if we're not meeting our goal ionized calcium within the circuit, are we going to adjust our citrate or our calcium infusion? Citrate, yeah. So the patient ionized calcium is going to be drawn from the patient, not anywhere from the CRT circuit, and our goal ionized calcium for those patients is 1 to 1.3. Okay, so it's important to kind of recognize you're going to have two ionized calcium levels on your labs at pretty much drawn at within 2 minutes of each other. And so we need to be cognizant of the fact that if a patient is on CRT, you need to know which calcium level you're looking at. Because you're going to have to be able to titrate drugs based on that. So if a patient isn't meeting their goal ionized calcium that's drawn from the actual patient, we're going to adjust what drip? The calcium drip, yes. And this is actually done per nursing protocol here. The nurses have a titration on their MAR, and they will be titrating that drip based on that. Citrate should be done per physician order only, okay? So I just want to briefly talk about citrate dosing, and I'm really focusing on this because we've recently, within the last week and a half, changed the citrate that we're using. And these orders are coming through to pharmacy to verify, and so you guys are going to see this. So we are using something called ACDA, which is a much more concentrated form of citrate. And the dosing is you start the rate at 1.5 times the blood flow rate, okay? So typically, we're going to start a blood flow rate off at 200 mils per minute on our CRT circuit. And so when you're reviewing orders and you get an order for this ACDA citrate, that's what you can verify. You can look at the dialysis orders and say, oh, they ordered a blood flow rate of 200. My citrate rate should be what? 300 mils per hour. Yep. This is a table that's built within the order set for the physician to use. And I will draw your attention to the fact that it's not exactly 1.5 for some of these values, and that's because the pumps don't go down to the 5 mLs. They only go to 10 mLs. But this is available, and I've got a dosing kind of sheet that I can provide to pharmacy as well if you guys are interested in looking at that. So then our calcium dosing is going to be similar to what we were doing before, but now the nurses are going to start their calcium drip based on what their citrate rate is. Prior to going live with this protocol, they were just starting at some random number, no matter what citrate dose we were ordering, and it would tank their calciums, and we were kind of running into issues. So now we've kind of systematically thought about this and decided, okay, if we've got this dose of citrate, we're going to need this much calcium. And so this, again, is on the nursing MAR for them to see, but you guys may get questions about this, and so that's why I'm bringing it up. I've got the starting rates. per the citrate rate for both the standard concentration and the double concentration calcium drips. And then their titrations are going to be the same. This is not changed, and I've just provided this here for completeness sake. But if you guys get a new nurse that's running CRT, they may call and ask questions about how to adjust the calcium drips. So citrate is rapidly metabolized by the liver and kidney and muscle cells, and sodium bicarbonate is a byproduct of the citrate metabolism. So it does act as a buffer in these patients, which is good because a lot of these patients are acidotic to begin with. But it does have some metabolic consequences. So it can cause metabolic alkalosis if we overdose someone. It can cause metabolic acidosis in the setting of severe liver failure or hypoperfusion when they're not able to metabolize that citrate to bicarb. Can cause hypernatremia due to the sodium content of the actual ACDA product. Hypo or hypercalcemia would be due to inappropriate calcium supplementation. And then hypomagnesemia, I honestly have never seen the citrate cause hypomagnesemia, maybe in toxicity cases, but on a routine basis, these patients don't get hypomagnesemic. So the risk factors for citrate toxicity, biggest one here is liver failure. If you've got somebody with liver dysfunction or could potentially have shock liver, status post cardiac arrest, I'd be very, very leery about using citrate in these patients. Other risk factors, obviously overdose. If a nurse hangs the citrate on the wrong pump on the CRT machine, that could be deadly. And has happened. I went to a conference this summer, and this happened at UAB actually. So it is possible. It is high risk med. So detecting citrate toxicity is something I really want you guys to be aware of, especially if you're reviewing patients' profiles in the ICU. Things that you're going to see are a rising anion gap, worsening metabolic acidosis. You'll see this falling of your systemic ionized calcium, but your total ionized calcium level will start going up, okay? If you're looking at your calcium drip rates and they seem to be escalating and you're still not reaching your calcium goals, you need to really be thinking about that and saying, do we need to change off of citrate to something else? So there is a calculation that you can do to kind of look at this ratio. So if you take your total ionized total systemic calcium and multiply that by 0.25 and divide that by your systemic ionized calcium, if this ratio is greater than 2.5 to 1, your patient probably has citrate toxicity and you need to stop citrate immediately. Okay. So enough about citrate. We'll talk about heparin. So heparin can be given systemically. So, for example, in the CV-ICU patient population, a lot of those patients are on systemic heparin drips for other indications. And so we don't need to provide additional anticoagulation on top of that. They're already anticoagulated, and so that would suffice for circuit anticoagulation. But we can also provide heparin via a syringe pump on the CRT machine. And I know this may be difficult for you to see, but on the side of the CRT machine, there's a syringe pump that's actually built in. And a 20 cc syringe fits on this pump. And we provide a concentrated heparin syringe, and the concentration is 500 units per ml on this pump. So sorry guys. I don't know why it just did that. Okay. All right, here we go. So if you do not have somebody systemically anticoagulated on heparin and would like to use heparin anticoagulation, it can be provided more directly to the circuit, and we're not targeting the same PTT goals that you would if you were systemically anticoagulating someone. So our goal PTT here is 40 to 52 seconds, not 50 to 70. Or your titration here is here. And again, this is built into the MAR for nursing. So I bring this PTT goal up because we really don't know at what point, what PTT level a patient would be considered therapeutic or prophylaxed for DVTs, okay? And so there are times when you're going to see somebody on this heparin syringe that would also be on sub-Q heparin for DVT prophylaxis, and that is okay, okay? Because we don't really know at what PTT level a patient is adequately prophylaxed for DVTs, okay? So if you do come across that situation, that is okay. That would not be considered a duplicate in therapy. And I know we talk a lot about duplicate anticoagulants, but this is going to be one of those times where it would not be inappropriate. Okay, just a few kind of pearls about when we're comparing citrate to heparin. Heparin is obviously much less expensive than citrate. It's got a short half-life, it's reversible, it's widely available, and it's probably much cheaper than the citrate because it doesn't require the ionized calcium monitoring like the citrate does. But it does have risk of bleeding. You have to monitor for it still. You can develop heparin resistance and obviously cannot be used if patients have a history of HIT. Citrate has reduced bleeding risk, but does, again, have some consequences if it's not managed correctly. So all of those things we had already talked about, and it does require a very strict protocol and people that really are have been trained to do that. Citrate has been studied, and they've looked at citrate versus heparin anticoagulation with CRT circuits, and most of the studies will show that citrate, when using citrate, you have longer filter lives, you've got less spontaneous filter failure, patients require fewer transfusions, and you've got less incidence of bleeding. No surprise there. But again, we can't use it for everyone. The KDIGO guidelines do recommend using citrate in patients over heparin if they can tolerate citrate. So as long as they don't have liver dysfunction or some other contraindication, citrate is preferred over heparin. I want to briefly talk about CRT solutions. I know I kind of mentioned this earlier, but just so you guys are aware of what those could, because these orders are now going to come across to verify, and I want you guys to be aware of what we're talking about or what you're looking at. So the CRT solutions should contain a buffer, and they contain electrolyte concentrations that are normal physiologic concentrations because we're dialyzing the patients to a similar concentration, okay? So calcium-free solutions, again, should be used when you're using citrate, and standard bicarb solutions are preferred unless the patient's pH is less than 7.2. We only carry 2 products here at Erlanger, so those are the only 2 I'm going to talk about. We've got the BGK 4 2.5 and the BGK 4/0. So the 4 is going to refer to the potassium content in the bag, okay? And the second number, the 2.5 or the 0, is going to refer to the calcium, okay? So the 4 2.5 should be used if your patient is not on citrate, and then the 4/0 should be used if the patient is on citrate. That's the biggest difference between the 2 bags. The other difference that I want to draw your attention to is the bicarbonate concentrations. So we were talking about high bicarb versus normal bicarb concentrations. So the calcium-free has a normal physiologic bicarb concentration, and the 4 2.5 has a higher bicarb concentration. So the caveat to that, not using calcium-containing solutions, is that if your patient is severely acidotic and you need to get rapid correction of that acidosis, the physician may choose the 4 2.5 because it's got a higher bicarb concentration. Okay. once that acidosis is corrected, they should switch. Okay. So now, drug dosing. This is probably what you guys are really care about. So unfortunately, package inserts don't typically provide dosing recommendations for CRT. Lexicomp or UpToDate will have recommendations for some drugs, but not everything. And we'll always run into situations where we really can't find much except primary literature. So I caution you when interpreting and looking at primary literature in drug dosing with CRT that you pay attention to the different CRT methods and CRT dosing that was used, because that will greatly affect the dose and how adjustments are needed in that study. I also provided this link, and if you Google, I'm pretty sure if you Google CRT drug dosing, this link will come up, and they actually have really good recommendations on this site, so it's a good resource if anybody's looking for a resource to use. So there's drug-related variables and the CRT-related variables that are going to affect how we dose drugs. So the drug-related variables that we'll talk about are the clearance, the drug size or molecular weight, and then protein binding and volume of distribution. So if the drug is cleared by the kidneys and it's greater than 25 to 30% of the drug is cleared by the kidneys, then you would expect that the extracorporeal clearance by CRT would be significant. So drugs with high non-renal clearance are not going to have clinically significant removal from the CRT. So a general rule of thumb is if you have to renally dose adjust it, then you really need to assess how you're going to adjust it with the CRT. So for example, Levaquin has about 80% renal excretion and does require dose adjustment for CRT, whereas Moxie has about 20% renal excretion and does not require dose adjustment via CRT. So drug classes, you can't automatically say that all quinolones have to be dose adjusted for CRT, because that's not accurate. You really have to look at the drug properties. So drug size and molecular weight will also affect whether they need to be dose adjusted or how much they'll need to be dose adjusted. So smaller molecules are cleared by diffusion better, okay, so CVVHD, whereas convective clearance actually is pulling those solutes across that filter membrane, and so it's going to clear larger molecules because it's got that hydrostatic pull. So CVVHDF, which is what we run here, combines both of these. So both small molecules and middle-sized molecules are going to be removed. And just for your frame of reference, vancomycin sits around, I think it's about 1,800 to 2,000 Daltons. I don't remember the exact number. Penicillins, cephalosporins, carbapenems, fluconazole are all kind of in this middle to low size molecule. So these are all drugs that typically need to be dose adjusted for CRT. You can see albumin up here, myoglobin is up here. Those things are typically not removed via CRT, and if they are, it's more due to like filter adsorption versus actual clearance. Okay, and then you've got your electrolytes, urea down here, and those obviously are very readily cleared by CRT. So protein binding is another thing we have to think about. Only non-protein bound drugs are going to cross that membrane, and so highly protein bound drugs are going to have less clearance via CRT. Volume of distribution is also important when we're talking about lipophilic versus hydrophilic drugs. So if you've got a drug that's very lipophilic, it probably has a larger volume of distribution, and so it's distributed into the tissues and not in the plasma. And so when most of the drug is in the tissue, it can't be removed by the CRT. We do have to keep in mind that there's obviously big alterations with patients that are critically ill, things like blood loss and fluid shifts, vomiting and diarrhea, that's pretty consistent, and changes in protein binding in these patients can also affect the volume of distribution. So drugs that are lipophilic, fluoroquinolones, digoxin, linazolid, are more tissue-based drugs, and hydrophilic drugs, things like aminoglycosides and beta-lactams, don't typically have as high of a volume of distribution and are more readily cleared. So if a drug has a volume of distribution of greater than 3 liters, it kind of indicates that it's more found and is found more in the tissues and outside of the plasma. And so again, only drugs within the plasma are going to be dialyzed. So let's kind of put all of these drug properties together and think about a patient case. So let's say you receive a consult to adjust medications for CRT, which we do commonly get, and the patient is on drug X. And you look in your resources and you can't find dosing for CRT for this drug anywhere. But you're able to find the pharmacokinetic information in the package insert. And it says that it's 50 to 70% cleared by the kidneys. It's 780 Daltons, so medium to small size molecule. It's 25% protein bound, but its volume of distribution is around 500 liters. Do you guys think that this drug is going to be cleared by CRT? No. And this drug is actually digoxin. So I bring this example up because we do have to, digoxin is a drug that's renally dose adjusted, but it's not removed by the circuit. And so it's not a steadfast rule that all drugs that are renally cleared have to be adjusted. That's a good starting point, but you can't assume that just because it's renally cleared, it's going to have to be adjusted in CRT. And there's the dosing there in case you ever run into that situation. I've provided a list here of some antibiotics, antifungals that don't require dose adjustment for CRT. I get question about micafungin a lot, question about linazolid a lot. Those do not have to be dose adjusted, so normal dosing is okay for those. So now we've talked about drug variables. Let's talk about CRT-related variables and how the CRT order and modality is going to affect drug dosing. So we'll have to look at modality. The filter we're going to talk about, but we only have one filter here, so it's not going to be a huge factor. Dilution, filtration fraction, and dose, and we'll talk real briefly about each one of these. The CRT modality, like I mentioned earlier, is different and provides different types of clearance. So if you're providing CVVH, CVVHD, and CVVHDF, the clearance of small molecules is going to be similar if you're using the same effluent dose, okay? Now, when we're talking about larger molecules, like our antibiotics, vancomycin, it's going to be different. So CVVH is our convective clearance. And remember how we said convective clearance is pulling those molecules across that membrane. So you're going to get higher clearance with a convective process. CVVHD is going to combine those two methods. So that would be kind of our next in line as far as clearance-wise. And then CVVHD is going to clear the least for larger molecules. And again, this is all assuming you're using the same effluent dose. So the filter membrane is a factor, not something that we really have to worry about because, again, we only have one filter choice here. But membranes that are more permeable are going to clear more drug. We do need to think about membrane charge, although it's usually not sufficient enough to affect our dosing. We have a polysulfone filter, and it's not charged at all. The only thing I will point out, and Kyle's probably the only one that cares about this, is colistin does absorb to the membranes. About 40 to 60% of its clearance is because of membrane absorption. HF 1400 is the filter that we use in case anybody is curious. When we're talking about dilution, we're talking about the replacement solution that we're providing in CVVH modalities. And so, like I said, you could provide replacement solution either pre-filter or post-filter. Okay, when you provide replacement solution pre-filter, you're essentially diluting out the blood before it's going to run through this circuit. Does that make sense? So you're not going to get as much clearance because you've diluted out the blood before it's going to run through the filter. So this is good when we're talking about filter clotting, because the more dilute your blood is, the less issues you're going to have with clotting. But you're also going to get less clearance, okay? So if you have high pre-dilution rates, you're going to get slower rates of drug clearance. Filtration fraction is something that's probably not super important to you, but if you are rounding and you notice that the CRT machine is constantly off due to filter clotting, this may be the reason. So filtration fractions of greater than 30% can lead to filter clotting. I have provided the equation here for completeness sake, but I don't expect anybody, and I don't calculate this because our machines tell us what it is. And so when you're looking at the machine, filtration fraction is going to be the last value that you're going to see, and it'll be a percentage. So if you're seeing a filtration fraction of greater than 30%, and you're having a bunch of issues with the CRT filter clotting, your solution rates need to be adjusted. And the nephrologist or critical care service will be able to do that, but that can be an issue sometimes. So CRT dosing, again, is going to affect our drug clearance as well. And I want you guys to be mindful that the dose that's delivered is always less than the prescribed dose that the patient gets. So you have to think about all the times that those patients go down for CT, for surgery, have to leave their room for any reason. That CRT machine is not running, okay? Every time that patient, they have to change a bag on that machine, that CRT machine is not running. So your dose delivered is always going to be less than your dose prescribed. So keep that in mind when you're assessing the dose that the patient has been prescribed. So there's been some studies done comparing low dose CRT, so they define that as 25 mils per kilo per hour, versus high dose CRT, which they prescribed 40 mils per kilo per hour, to look at mortality and then adverse effects. And so there was no difference in 28-day or 90-day mortality between the two dosing groups, and the higher dosing group had higher rates of hypophosphatemia, as you can imagine, because their clearance was much higher. So the KDIGO guidelines recommend using a dose of 20 to 25 mils per kilo per hour, but also being able to recognize that the patient probably isn't going to get that 20 to 25 mils per kilo per hour. And so really, typically we're going to prescribe 25 to 30 mils per kilo per hour, and that would be considered a normal CRT dose. I will say that nephrology has at times run very, very high CRT dosing, and so it's important to kind of pay attention to this and what service is running the CRT, because there will be drastic differences. Nephrology will run somebody at 80 mils per kilo per hour, and surgical critical care will stick with that 25 to 30. I point that out because your drug dosing is going to be drastically different, especially when we're talking about vancomycin with those two different dosing strategies, okay? We are working to try to get nephrology to come down on their dose a little bit, but I just want you guys to be aware that it is a big factor, especially when we're talking about vanc. So just some kind of food for thought and why mortality probably wasn't different. When we're looking at patients that are on CRT, critically ill in the ICU, a lot of them have sepsis, have some kind of underlying infection that we're trying to treat. And this is kind of just a graphical representation of antibiotic concentrations when CRT is prescribed at 40 mils per minute compared to 20 mils per minute. You're obviously not getting your meeting your concentration dependent targets or your time dependent targets. Your ADUC to MIC ratio is still drastically different when you're using that higher CRT dose. So when we're talking about mortality in these patients, a lot of these patients will end up dying from an infection. And so typically we are underdosing on a lot of things, especially antibiotics. So when I'm talking about CRT dose, what am I talking about? You'll hear the term effluent dose, and that's what's going to read on your CRT machine that you're looking at. And there's an equation that you can use to calculate this, but again, this is also provided on your CRT machine screen, so you can look at that if you don't want to do the math. So if you take your pre-filter replacement solutions, post-filter replacement solutions, your fluid removal rate, and then any pre-blood pump fluids, pretty much all the fluids that the patient is getting through the dialysis circuit, and divide that by the patient's weight, that will give you your effluent dose. So an easier way to look at this is if you're taking your replacement solutions and your dialysate, add that up and divide by the patient's weight, that's going to give you a good rough estimate. Don't worry about your ultrafiltration fluid removal rate. It's negligible when we're talking about dose, okay? So this is a picture of the screen, so if you don't want to calculate this, effluent dose is what we're looking at on the CRT machine screen. And if you pull up the CRT flow sheet in Epic, the nurses also input what this effluent dose is in that flow sheet. So again, you don't have to do the math if you don't want to. So let's do an example. If you've got a patient that's placed on CVV-HDF for AKI, secondary to septic shock, their CRT parameter orders are below here. So they've got a blood flow rate of 200 mils per minute. They've got an ACDA rate of 300 mils per hour on your pre-blood pump. So this is a replacement solution per se. You've got dialysate at 1,000 mils per hour and your replacement solution at 1,000 mils per hour, and you're doing a fluid removal of 100 mils per hour. And we've got our CRT labs down here. We've got a post-filter ionized calcium of 0.3, which is perfect, a systemic ionized calcium of 1, which is also perfect, and a serum total calcium of 8.2. So it looks good, right? So what's our patient's CRT dose? Our patient's 80 kilos. So we've got our ACDA right here, 300 mils per hour, our dialysate right here, our replacement solution right here, and then our fluid removal rate. And so we add all those up and divide by the patient's weight, and you get an effluent dose of 30 mils per kilo per hour. So prior to CRT initiation, the following medications were ordered for the patient. She's got Tylenol, Zosyn, vancomycin, pulse dosing, Lovenox, and Protonix. So you as a pharmacist need to adjust your medications now. So how are you guys going to do that? Do you want to adjust the Tylenol? No. What about the Zosyn? Yeah. We'll change Zosyn to 4.5 grams Q8 hours. Vanc pulse dosing probably needs to be changed. I would do 1250 Q18 in this patient. So patients that are on higher effluent doses of Vanc, so I'm saying probably greater than 35 to 40 mils per kilo per hour, I'd recommend Q12 hour Vanc dosing on them. And I typically do not give them 15 mg per kg. I do more like 10 to 12. Lovenox I would change to sub-Q heparin, and the Protonix does not need to be changed. So let's say that shift change occurs and the nurse rushes to change the CRT bags, and the new nurse calls you and says the patient's systemic ionized calcium is 0.7. Good or bad? Bad, right? The systemic calcium, we want 1 to 1.3. And the patient's blood pressure is dropping, they're requiring escalating doses of vasopressors, and they've got a prolonged QTC. And so you pull up their labs and you notice the systemic total calcium is 10.8. So that's a pretty significant increase. Their systemic ionized calcium, again, is 0.7. Their bicarb is 37, and their sodium is 154. What are you guys concerned about? Citrate toxicity. So I've kind of done the math here for you, but you're going to take their total calcium multiply by 0.25, and divide by the patient's systemic ionized calcium. And so their ratio is 3.9, much higher than 2.5. And so this patient is citrate toxic and needs to be immediately stopped on CRT. Stopped on citrate, not CRT. You need to continue the CRT, sorry. Stop the citrate, keep the calcium drip going until that's corrected. Do you guys have questions? Yes.
Is there a way in Epic to tell the difference between the calcium levels? Like if you click on the lab, will it tell you which one?
Bree, will you repeat the question?
Oh,
She doesn't have a microphone.
yeah. So the question is there a way in Epic to tell the difference between the blue port or the circuit ionized calcium and the patient ionized calcium? And no, there is not. And we have asked and asked and asked, and I'm sure that we've been told no and no and no. So you are looking for two ionized calcium levels that are drawn within 5 minutes of each other, and you should be able to tell which one is the patient and which one is the blue port ionized calcium. But if anybody has any pull with Epic. Anybody else?
Thank you.
Ooh.
I feel fancy. So in calculating the effluent dose, is there any significance in patients who are morbidly obese in terms of what weight you should use to calculate their effluent dose? And is what we should use the same thing that will pull in for the nurses when they're calculating the effluent dose?
So the machine calculates the effluent dose on the machine, and they are to use the patient's actual body weight. So you should always use the patient's actual body weight.
Thanks.
Yep. Yeah, okay.
Thank you, Bree.
You're welcome.